Okay, hey, welcome back to another awesome case. So this case, what we have here, we have a liver biopsy, and it's a patient who has a history of like, okay, this was a case I got from like a while back, maybe like 1 or 2 years ago, a long time ago, and I saved a recut of it and I scanned it. So check this out. Okay, so this patient had urothelial carcinoma like a while back, and then they're coming here with, I guess, like increased liver enzymes. They're getting like chemo and stuff. They're on their chemo regimen and whatnot. But they were suspicious for like a mass, and they got a targeted biopsy. So this case is crazy cool because I've seen cancer do this a few times now. It's very, very sneaky. So let's just like kind of ride through this biopsy and just kind of see what's going on. So I won't focus too much on the medical liver aspect. I'm going to focus more on the tumor neoplastic aspect. So like, this is the first level because we get like 10 levels of this biopsy, and then some of them are filled in with like special stains and stuff. So this is the first level, and like you're kind of going here, and it depends. Like, do you look at these cases blind? Do you look at these cases with history? That I think that all depends on your style or your preference. Sometimes I like to do it blind, sometimes I like to do it with history. But if you're going here on 10x, right, and you get to about this section, like you may not, it may not necessarily catch your eye right away. It's always like typically off to the side, like what is this? Is this even real? But the fact that when I initially looked at this case briefly, I was like, okay, I don't think I see any tumor. But then I read the history, and I was like, okay, okay, I have to look at this case again and look for some sort of neoplastic disease. And here we go. There's like, what cell is that? Is that a hepatocyte? Maybe. Could be some sort of squished hepatocytes, but it's not enough, right? It's just different. It's different. The vibes are not right. So we kind of like scroll through it, and yeah, just kind of weird. So let's go to the next level, and then we get again the same part, and you can kind of see the cell again. It's let it load up. Like, check this out. Like, here's the bile duct. Here's like some sort of little artery, and then here it's like, oh, could be a squished bile duct. Can't say much, right? So for this case is what we started getting more levels. Again, here funny cells, but nothing that you will pull the trigger on and call like atypical or neoplastic. So let's keep going. So our next step was like, okay, let's look at the other levels on this biopsy. So here we go. This is the 10th level of the biopsy. So let's take a peek through it real quick. Um, let's drive through it and see what's up. Again, here, not too much action. Let's go to the area that I dotted. That is pretty high yield. Like, here we go. Here we go. So this is like, you get to this portal tract. And I've seen cancers do this several times now. They will hang out in the portal tract area and look totally, totally chill. Like, you won't even expect it. But here, check this out. So let's go in high power. Like, there's a bile duct, and then it just looks busier than usual. And then you see this cell right here. What is that? Maybe a histiocyte, right? Still not enough. Atypical, but just not enough. What about, let's go to another area that's a similar area on a little deeper level. And I think this right here is what really started clinching it, because you get a bile duct, right? You get a bile duct hanging out here, and then, like, what's that? What is that? Like, plasmacytoidy kind of like lymphocytes, maybe, but it's just such a little cluster, so it's just weird. So we went ahead and we got a bunch of levels for this case, and let's look at those levels, because that's where things get really spicy. Oh my god! And this is the part that I also wanted to show. Check this out. Like, what is this cell over here? What is this cell? What is this? What is this? So again, you're looking at this and you're like, you could see how if you kind of go through this case and you're not careful, you could this could totally be missed. It's so subtle. It is so subtle. So so we got levels. Let's look at those levels, because then things get really spicy. Okay, here is a level. I think this is like level like 14 now or something. But here is where the plot thickens. And this is when you see stuff like this, when you see stuff like especially like this, I'm like, this is cancer. This cannot be anything other than like this can't be normal, right? This can't be like a bile duct or some reactive. So here, as cluster of atypical cells, cancer. I've seen this happen several times now, where in a bile duct area, the rest of the liver looks pretty chill. There's nothing there, but in the bile duct area, there's like a focal cluster that, especially if it's a well diff, moderate diff, cancer, you could be like, oh, it's just a bile duct or whatever, and you just could pass it by. I have another case on my Twitter where I posted, and it's just like that right here, like just like these funny glands. So we went back and we pulled the prior case from like so many years ago just to take a look at what it was, right? So let's take a look at that. Wow. Okay, boom. So this is a case from a while back, right? And this is the bladder resection for, bladder urothelial carcinoma. And we started looking at this thing, we're really, really looking at this thing. And we're like, holy poop, look at these cells. Look at these cells. This is cancer. This is what we're seeing on this liver biopsy. They got this like plasmacytoid kind of vibes, features. You have like a nucleus here, and then you have this eosinophilic, amphiphilic cytoplasm just kind of getting pushed off to the side. So that is some real stuff right here. That is some real stuff. And here, check this out. It's kind of bursting through, going right over here, pushing into this stroma. And look at these glands, eosinophilic, amphiphilic, a little nucleus popping off to the side, and holy moly macaroni, this is our tumor. And I'll show another area, mostly because I didn't know this at the time. So this was signed out as like urothelial carcinoma with plasmacytoid features. Now, some people will be like, "Oh yeah, plasmacytoid, not a big deal," but it's a very cool case. It's very unique. So check this out. It's cool because it was so sneaky on that liver biopsy, and two, because check this out. Look at these cells. They're plasmacytoid. It's a plasmacytoid urothelial carcinoma. Well, sorry, it's a urothelial carcinoma with plasmacytoid features. Right now, that is pretty different. You know. So let's see what the literature has to say about this. Okay. So I googled this stuff and I was like, what is a plasmacytoid urothelial carcinoma? Because I haven't really seen one before, and it's a urothelial carcinoma variant. It's not a common one. It's associated with, oh, let's put this over here. Where is this at? Published in 2018. So it's not that. It's pretty recent, relatively recent, in archives of laboratory medicine and pathobiology. And it's a plasmacytoid urothelial carcinoma. It's a variant of urothelial carcinoma, and it's got these tumor cells that look like overlap with plasma cells, and they can harbor the CDH1 mutation. So that's cool. I didn't know that. And generally, these are more aggressive. They have uh, generally worse outcomes, and they present at a higher stage. So for these cases, like if they get upfront consideration for cystectomy and PT1, and just be aware that this exists. There could in urothelial carcinoma, there's a bunch of different morphologies that you can have, and then they make up about 20 to 25% of urothelial carcinomas. And then this urothelial carcinoma, it's unique because they look like plasma cells, which is crazy, and it has aggressive behavior. It's lumped. Um, it's lumped in that bad category along with signet rings, diffuse urothelial carcinoma, and similar to, the plasmacytoid. Like those are the bad actors. It was first described like not even that long ago. Like it's what 2024, right? Right now when I'm recording this video, 91. This was described 30 years ago, in a 63-year-old gentleman who presented with metastatic lesions to like ribs and stuff, and it was misdiagnosed. It was misdiagnosed as as a multiple myeloma, which is wild. And then later it's been kind of like talked about more, and you could totally see. Like I'll skip all this. You could read this on your own. Like the high yield parts that I want to talk about is like their outcomes. The survival of plasmacytoid urothelial carcinomas is when it's matched to conventional is actually lower. It's like almost 50% less, because you know, yeah, survival is 4.1 years and matched conventional is 8 years. So these are more aggressive variants, and they do stain like the plasma. Sorry, they do stain like normal conventional urothelial because they are urothelial. So you can expect like GATA3, P63, S100, CK7, 20, Europlakin, and GATA is the more sensitive when you compare it to like P63. Crazy part about this one is, and I didn't know this, but from my reading, it's like these these yeah, as I was saying, these cases again, yeah, they stain for CD 138, which is a plasma cell marker, which is very cool. Like you don't get that many. I mean to me that's cool, right? To me that's cool. So just a high yield factor. So let's look at the cytology for these cases because this is not. Oh wait, what where is it that they like? They also say how many cases of these account for incidents or something. But oh, check this out. This is cool. This is why this case is cool. This case, in most contemporary series from tertiary institutions and so on, this type of variant accounts for 1 to 5% of all urothelial carcinomas. So this thing is rare. It is rare, and it's good to keep in mind. So check this out, right? I mean, here it's kind of an okay picture, but this is a nicer picture. You can see there's plasmacytoid-like cells right here. Here again, plasmacytoid, and here they look like kind of like lobular-like pattern, single filing getting into that stroma. But I feel like these right here, this one right here, is what kind of matches our case the most. Ours definitely has more atypia. It has more striking atypia compared to here, but here it kind of looks like that. And then here, check this out. This is wild. So CD138 stains these cells. In the original case that we have, no, you know, we didn't stain. They didn't get stained for CD68. Um, so while it has plasmacytoid features, it could be a plasmacytoid features, or it could not, but it was never confirmed for one CD138. I kind of wish we did it retrospectively or something, because that would have been super cool. It also stands for like GATA3, these guys, and ECAD right here. This is like, I guess, the invasive component. It's hard to say, but they're saying ECAD is lost. So anyways, um, yeah, high yield here is ECAD is, lost because there's CDH1 mutation. They stain for CD138, and they're associated with kind of a more advanced stage presentation. And this is a paper by Sadika and Gladell, and yeah, so check it out. It's a pretty sweet paper. Again, don't forget to smash that like and subscribe button, and yeah, I'll post more videos. Super cool cases, totally cool. Thanks for watching. See ya.